All right, let's get started. Please, have a seat. We're going to work through a common but absolutely critical emergency scenario. I want you to treat this as if it's happening in real time. Your decisions matter. So here's the situation. You are the on-call surgical consultant. The emergency department just called. A 68-year-old man has just been brought in. He collapsed at home complaining of sudden tearing back pain. When he hit the door, he was pale, sweaty, and his systolic blood pressure was 85. The clock is ticking. Okay, so I want you to walk me through this. We'll start with the initial clinical scenario and your assessment. Then we'll cover resuscitation, how you're going to confirm the diagnosis and plan the operation. We'll get into the specifics of the repair itself and, of course, post-op care. And along the way, I want you to highlight the key learning points and any red flags. Let's begin. Let's go back to that patient in the ER. 68-year-old man, hypotensive, severe back pain. What's going through your mind?
So, tell me, based on the classic triad of symptoms, what is your primary diagnosis? And I want you to state that triad for me.
Thank you. Well, with that presentation, my number one diagnosis, without a doubt, is a ruptured abdominal aortic aneurysm, or AAA. The story fits perfectly with the classic triad, which is, first, hypotension, second, that severe abdominal or back pain, and third, a pulsatile abdominal mass. So while I'm getting the story, I'm already moving to do a very focused, gentle exam to feel for that mass, and at the same time checking his femoral pulses to make sure he hasn't completely occluded the aorta. And I have to stress, this is a time-critical surgical catastrophe. The mortality rate for a ruptured AAA is incredibly high, somewhere between 80 and 90%. You know, many of these patients don't even make it to the hospital. So every single second from this point forward counts. My entire plan is about one thing, getting to definitive aortic control as fast as humanly possible.
Correct. You've identified the threat. Now the patient is in hemorrhagic shock right in front of you. You have your working diagnosis. What happens next?
He is hemodynamically unstable. What are your immediate management priorities in the emergency room as you're getting ready to go to the operating theater? My absolute top priority is controlled resuscitation, and this is all governed by the concept of permissive hypotension. The whole idea here is to avoid aggressively jacking up his blood pressure. If we do that, we risk blowing off the contained retroperitoneal clot that might be the only thing keeping him alive right now. It's all about damage control, just enough fluid to keep his brain and organs perfused until we can physically clamp the aorta.
And this all has to happen at once. First, I need my team to get at least 2 large-bore IVs in, and I'm activating the massive transfusion protocol with the blood bank right away. We're sending off blood for a cross-match and a full set of labs. Second, I'm carefully titrating blood products, packed cells, FFP, and platelets, ideally in a 1-to-1-to-1 ratio with a very specific target, a systolic pressure of about 80 to 100, just enough to keep him conscious. Third, and this is a massive red flag, I'm telling everyone in the room, we do not intubate this patient, not yet. The induction drugs will kill his sympathetic drive, the very thing holding his pressure up, and he will almost certainly arrest.
That's a very clear and critical point on intubation, a classic pitfall. Okay, so you're preparing to take this patient for definitive treatment.
The patient is still unstable. Do you need any imaging to confirm your diagnosis before you head to the operating room?
No. For an unstable patient like this, absolutely not. The clinical diagnosis is enough. The operating room is the only place he has a chance. Any delay for a CT scan is a fatal delay. Now, if someone can do a rapid bedside fast scan in a few seconds without slowing down our trip to the OR, that's fine. It can confirm the aneurysm, but it's not required. Of course, if this same patient were hemodynamically stable, the story would be completely different. He would get a CT angiogram, which is the gold standard. That would not only confirm the rupture, but give us that crucial roadmap of his anatomy needed for endovascular planning.
Good. You've made the decision to operate immediately. You're now in the operating theater. So what are the definitive treatment options on the table for a ruptured AAA? And more importantly, for this specific unstable patient, how are you going to choose? We have 2 main options. First is the traditional open surgical repair. A big midline incision, we find the aorta, and we sew in a graft. It's the classic approach, it works for any anatomy, but it's a huge physiologic hit on the patient. The second option is endovascular aortic repair, or EVAR. This is the minimally invasive technique done through the groin. The advantages in a rupture are pretty compelling. You can sometimes do it under local, it avoids massive fluid shifts, and it keeps that retroperitoneal tamponade intact. The choice really boils down to 3 things: patient stability, their specific anatomy, which we don't know here, and what our hospital can do right now.
Do we have an endo team and a hybrid OR ready to go this second? Given how unstable this guy is, the fastest, most reliable option is often the open repair. If we're going with an open repair, the guiding principle is really about being as simple and efficient as possible. We need to minimize the insult. The key steps are a fast midline laparotomy, get immediate proximal control of the aorta, often just by pushing it against the spine, high up the diaphragm, and then dissecting down to get a formal clamp on. We open the aneurysm sac, stitch off any back-bleeding arteries, and sew in the simplest graft that will do the job. Then we close the old aneurysm sac over the new graft. It's all about speed and minimizing blood loss.
Now, if we were set up for EVAR, the steps are totally different. We'd start with getting access in both groins. Then, job 1 is to immediately thread a large occlusion balloon up into the aorta above the aneurysm and inflate it. That gives us proximal control and stabilizes the patient. Once that's done, we have a moment to breathe and do an angiogram to see where the renal arteries are and find a good place to land the stent. Then we deploy the main body of the stent graft, followed by the legs into the iliac arteries. And finally, a completion angiogram is absolutely essential to make sure we have a good seal and no leaks.
Very good. Let's assume you went with the EVAR and it was a success. The patient is now recovering in the intensive care unit.
The procedure went well and his blood pressure has stabilized. Tell me about a complication specific to this repair. What is an endoleak? And which type do we see most commonly?
An endoleak is basically a failure of the stent graft to completely seal off the aneurysm sac, so blood continues to flow into it. We classify them into 5 types. Now, the ones that are most urgent are type I, which is a bad seal at the top or bottom of the graft, and type 3, which is a leak between the graft pieces. Those are high-pressure leaks and have to be fixed immediately. The one we see most often, though, is a type 2 endoleak. That's a lower-pressure, retrograde flow from side branches like the lumbar arteries. We often watch those for a while because many will seal off on their own. Types 4 and 5 are much less common.
But really, endoleaks are just one piece of the puzzle. The biggest threat after a repair like this is multi-organ failure from that initial massive shock. So we have to watch for everything: heart attacks, kidney failure from the low blood pressure, and respiratory failure, or ARDS. Then there are the surgery-specific complications, things like ischemic colitis, which we watch for with rising lactate levels, or abdominal compartment syndrome from all the fluid we gave him. And of course, we're always monitoring for problems with the graft itself, like limb ischemia, or the worst-case scenario down the line, a graft infection.
Excellent. You've covered the critical aspects of this entire case. I have one final question for you. I want you to tell me the single most important, absolutely non-negotiable safety step when you take a patient for an open repair of a ruptured aneurysm.
The single most critical safety step, the ultimate red flag in managing an open rupture, is the timing of intubation. The patient cannot be intubated until they are on the operating table, fully prepped and draped, with the surgical team scrubbed, gowned, and ready to make an immediate incision. The second that anesthetic hits, the patient's compensatory sympathetic drive is gone, and they will likely have an irreversible cardiac arrest. Being poised with a scalpel in hand to get immediate aortic control is the only thing that can counter that. It's that coordinated dance between surgery and anesthesia that can make the difference between life and death.